Good afternoon, everyone. We, the Group 3, will be presenting our report on the eyelids and the nasolacrimal duct. The outline for today's topics are the eyelids. We will be talking about its surface anatomy, the internal structures, the anterior, middle, and posterior lamella, the eyelid margin, the movement of the eyelid, and its vascular supply. For the lacrimal system, we have the lacrimal gland, its innervation, the lacrimal ducts, and the common problems. For the clinical correlates, we have the eyelid middle lamella, the eyelid margin, the lash line, the meibomian glands, and the excretory apparatus. First, we will be discussing the surface anatomy of the eyelids. The eyelids are two thin, movable folds that protect the eye. The upper and lower eyelids are anterior structures. The upper eyelid is larger and more mobile. It has an elevator muscle called the levator palpebral fissure. The upper and lower eyelids close to protect the surface of the eye. They come together at the medial and lateral palpebral commissures on either side of each eye. They are both similar in structure, except for the additional two muscles in the upper eyelids. On the picture on the bottom left, we have here the palpebral fissure, this one, which is an open space between the eyelids. The medial commissure here, or the medial canthus, it is approximately 2 millimeters lower than the lateral canthus. This part here is the lateral canthus, or the lateral commissure. On the bottom right picture, we can see a small triangular space here that separates the medial canthus from the eyeball. This space is called the lacus lacrimalis, or the lacrimal lake. Within this space is a small reddish body of modified skin containing some fine hairs and is mounted on the plica semilunaris. This is called the lacrimal caruncle. The picture on the bottom will show the superior lacrimal papilla here and the inferior lacrimal papilla. They are small elevations located on each palpebral margin approximately 1/6 of the way along the medial canthus. The punctum lacrimale is a small aperture in the center of the papilla that forms the opening to the lacrimal drainage system. The ciliary part of the eyelid is the margin of the eyelid lateral to the lacrimal papilla, this area here. This is the area that has the eyelashes. The lacrimal part of the eyelid, its margin is medial to the papilla. This one. This is an area which lacks the eyelashes. The eyelashes are short, thick, curved hairs arranged in double or triple rows. The upper eyelashes are longer, more numerous, and they curve upwards, while the lower lashes curve downwards. This is so that the upper and lower eyelashes do not interlace when the eyelids are closed. The function of the eyelid is to protect the eye from injury and excessive light. This is done by contracting the orbicularis oculi, which initiates the reflex closure. Another function of the eyelids is to prevent the eye from drying. This is done by distributing lacrimal fluid, which keeps the cornea moist. Periodic blinking maintains a thin film of tears over the cornea, which prevents desiccation or eyelid movement during blinking. This ensures even distribution of the tear film.
The internal structures of the eyelid. The palpebral fissure is an elliptical opening between the eyelids and is the entrance into the conjunctival sac. The ciliary glands, also called the glands of Moll, is a modified sweat glands that open separately between adjacent eyelashes. The tarsal glands is a long, modified sebaceous glands that pour their oily secretion onto the margin of the lid. Their openings lie behind the eyelashes, and the oily material prevents the overflow of tear and help makes the closed eyelids airtight. The lacus lacrimalis is a small space that separates the or rounded medial angle. The caruncula lacrimalis is a small reddish yellow elevation found in the center of the medial angle. The plica semilunaris is a reddish semilunar fold that lies on the lateral side of the caruncle. Near the medial angle of the eye is a small elevation called the papilla lacrimalis is present. On the summit of the papilla is a small hole called the punctum lacrimale, which leads into the canaliculus lacrimalis.
So the eyelid consists of three internal structures, which is the anterior lamella, the middle lamella, and the posterior lamella. So let us start with the anterior lamella. It consists of the skin and the orbicularis oculi muscles. So the skin is 1 millimeter thick. It is the thinnest skin in the body. It is loosely adherent to the underlying orbicularis oculi. It has no subcutaneous fat. Its excess skin or bagging in the eye is called dermatochalacia, which is often cause of pseudoptosis. So as you can see here in the picture, here is the orbicularis oculi muscle, where the side parts are the orbital part and the palpebral part. So for the orbicularis muscle, the main protector of the eyelid, which has the narrowing and closure of the palpebral fissure. It is innervated by the temporal and zygomatic branches of the facial nerve or cranial nerve 7. It is divided into three parts: the orbital, preseptal, and the pretarsal, and is organized concentrically around the palpebral fissure. So the components of the orbicularis oculi muscle: the orbital component, which is the outermost aspect of the muscle. It is superficial to the corrugators and procerus. Its function is voluntarily closes the lid. The preseptal covers the orbital septum, and it has voluntary and involuntary movements. And lastly, the pretarsal, it covers the tarsal plate, and it is involved in involuntary blinking. Dermatochalasis is a condition which the skin above the upper eyelid is sagging and interfering with the function of the upper eyelid. It is common and usually occurs with aging. The surgical procedure to repair this condition is called blepharoplasty and can be done for cosmetic purposes or if the skin is sagging enough to interfere with vision. So as you can see here in the picture is an elderly man with bagging of the eyelids. And now we'll proceed to the next part, which is the middle lamella.
So I will report about the middle lamella of the eyelid. So we have the orbital septum. Orbital septum is a multi-layered sheet of fibrous tissue that forms the framework of the eyelids. It serves as a barrier between the orbit and the eyelid, and utmost function is to limit the infection and hemorrhage. And it arises from the rim of the periosteum across the marginalis. So here in the picture, this is the orbital septum. Also, it attaches to several muscle and ligament. Retractor muscle or aponeurosis or tarsus, and lateral cathal ligament and rim. Also, medial cathal ligament and posterior to the posterior lacrimal crest. Periosteum at the orbital margins, and lower eyelid fuses with the capsopalpebral fascia at interior tarsal bone. Thickened at the margins of the lids to form the superior and inferior tarsal plates. So, orbital septum also comprises the of lateral ends of the plates that attach by a band called the lateral palpebral ligament to a bony tubercle. Just within the orbital margin, the medial ends of the plates are attached by a band called the medial palpebral ligament to the crest of the lacrimal bone. The tarsal glands are embedded in the posterior surface of the tarsal plates. The superficial surface of the tarsal plates and the orbital septum are covered by the palpebral fibers of the orbicularis oculi muscle. Anteriorly, it fuses with the periosteum, and posteriorly, it fuses with the tarsus. We have also the fat pads or the refractor muscles. Fat pads by location compose of 5 fat pads and divided by the upper eyelid and lower eyelid. For the upper eyelid, we have 2 fat pads and consist of medial fat pad here and central fat pad. For the lower eyelids, it composes of 3 fat pads: the inferior obliquum, medial fat pad, and temporal fat pad. Retractor muscles are the upper eyelid retractors, is the levator muscle. It is for the eyelid elevation. The innervation of this is the cranial nerve 3 or the oculomotor nerve. Origin is the orbital apex. Insertion anterior to the 2/3 of the tarsus. Pretarsal orbicularis muscle, or the skin that the eyelid crease, has a size of 40 mm long, aponeurosis 14 to 20 mm long, and it pierces the orbital septum to reach the anterior surface of the superior tarsal plate and skin. We have the molars muscle or the lower eyelid retractors. The capsopalpebral fascia, origin of this is inferior rectus muscle, encircles the inferior orbital muscle. Insertion is the inferior tarsal border and forms the Lockwood suspensory ligament, formed by conjoining inferior rectus and inferior oblique fascia. Functions as suspensory sling of the inferior anterior orbit. Fibers to the inferior conjunctival fornix. Lower eyelid retractors, inferior tarsal muscle, is analogous also to the molars muscle, posterior to capsopalpebral fascia, and insertions at the inferior tarsal border and poorly developed. So the clinical correlation, we have the preorbital cellulitis, an eye infection of the eyelid or skin around the eye. It is an acute infection of the tissue surrounding the eye which may progress to orbital cellulitis with protrusion of the eyeball. Complication includes meningitis. Orbital cellulitis is an infection of the soft tissue and fat that hold the eye in its socket. Causes uncomfortable or painful symptoms. It's not contagious, and anyone can develop the condition. However, it is most commonly affects young children. Orbital cellulitis is a potentially dangerous condition. So we have here a comparison of the preorbital and orbital cellulitis. Both are infections that affect the tissue of the eye in front of and behind the orbital septum. For the periorbital cellulitis, affects the skin and soft tissues in front of the septum. Specifically, for the periorbital cellulitis, has no pain with movements of eye and vision is normal. For the orbital cellulitis, affects deeper tissues behind the septum, and specifically, the orbital cellulitis has pain with movement of the eye, double vision or blurry vision, and proptosis or bulging of the eye. So for the management, usually treatment most often includes antibiotics given oral or IV. Surgery may be needed to drain the abscess or relieve pressure in the space around the eye. An orbital cellulitis infection can get worse very quickly, so a person with this condition must be checked every few hours. That's all. Thank you.
Now let's proceed to the posterior lamella. The posterior lamella includes the tarsus and the conjunctiva. As seen in this picture, located here is the tarsus or the tarsal plate, and here is the conjunctiva. But let us first discuss the tarsus. The two tarsal plates are thin, elongated, crescent-shaped plates of firm, dense, fibrous tissue approximately 2.5 centimeters long. There is one in each eyelid to provide support and determine the eyelid form. It has attachments to the periosseum medially and laterally, and it contains the meibomian glands. The upper vertical height is 10 to 12 millimeters, the lower vertical height is 4 millimeters, and it is 1 millimeter thick. This is divided into superior and inferior tarsus. The superior tarsus, which is larger, is semi-oval and approximately 10 millimeters in height centrally. Its inferior edge is parallel to and about 2 millimeters from the lid margin. The smaller inferior tarsus is narrower and approximately 4 millimeters in vertical height. Now we go to the conjunctiva. The conjunctiva is a thin, transparent mucous membrane that extends from the eyelid margins anteriorly, providing a lining to the lids before turning sharply on itself to form the fornices. From here, it is reflected onto the eyeball to cover the sclera up to its junction with the cornea. The conjunctiva forms a potential space called the conjunctival sac that opens anteriorly through the palpebral fissure. The upper lateral part of the superior fornix is pierced with the ducts of the lacrimal gland. The conjunctiva is composed of non-keratinized squamous epithelium. It contains the goblet cells, which contributes the mucin component of the preocular tear film, and it plays a central role in the defense of the ocular surface against microbial infection. This also contains the accessory glands of Cross and Wolfram. The conjunctiva is conventionally divided into 5 regions. We have the marginal zone, as seen in this picture, the tarsal zone, the orbital conjunctiva, the bulbar conjunctiva, and the limbal conjunctiva. Let's first discuss the marginal zone. The marginal zone extends from a line immediately posterior to the openings of the tarsal glands and passes around the eyelid margin to continue on the inner surface of the lid as far as the subtarsal groove or sulcus. This subtarsal groove or sulcus traps small foreign particles introduced into the conjunctival sac. Next is the tarsal conjunctiva. This is highly vascular, and as you can see in this picture, it is firmly attached to the underlying tarsal plate. The orbital conjunctiva extends as far as the fornices, which marks the line of reflection of the conjunctiva from the eyelids onto the eyeball. Next is the bulbar conjunctiva. This is loosely connected through the eyeball over the exposed sclera, and it is thin and transparent, and it readily permits visualization of conjunctival and episcleral blood vessels. Lastly is the limbal conjunctiva that extends approximately 1 to 1.5 millimeters around the cornea. This contains a dense network of capillaries. An example of conjunctival infection is conjunctivitis, or commonly known as the pink eye or the sore eye. Conjunctivitis is an inflammation or infection of the transparent membrane or the conjunctiva that lines the eyelid. When small blood vessels in the conjunctiva becomes inflamed, they are more visible. That is why the white part of the eyes appears reddish or pink. Pink eye is commonly caused by bacterial or viral infection or an allergic reaction. Though pink eye can be irritating, it rarely affects your vision. Treatments can help ease the discomfort of pink eye. Because pink eye can be contagious, early diagnosis and treatment can help limit its spread. This picture below is a comparison of the different types of conjunctivitis. We have here the bacterial conjunctivitis. Remember that bacterial conjunctivitis has sticky yellow or yellow-green discharge. This can affect one or both eyes, and this usually spread by direct contact only. While your viral conjunctivitis is a type of conjunctivitis most commonly associated with the term pink eye or sore eyes. This has red appearance, this is itchy and watery. This can affect one or both eyes, and this is highly contagious. Lastly is the allergic conjunctivitis. As you can see, it is very similar in appearance to viral conjunctivitis, but this is accompanied by nasal congestion, sneezing, eyelid swelling, and sensitivity to light. So in allergic conjunctivitis, both eyes are affected, and this is not contagious.
The eyelid margin. So the eyelid margin is the area between the end of the eyelashes at the front side backwards to your eyeball, including the openings of the meibomian glands close to the eyeball. This is directed towards the palpebral fissure. So this entire free margin is covered by a keratinized epidermis, and this is around 2 millimeters wide. Its function is to protect the eyes against environmental influences and the management of your tears. So your eyelashes that grow from the anterior lid border protects the ocular surface against external influences, because when the lids approach each other, the lashes tend to constitute a meshwork, and this mesh acts as kind of a filter against dust and the entrance of insects. So the management of tears is achieved by the posterior lid border. So this is in touch with the eyeball by the slightly thickened epithelial cushion that is termed the lid wiper. This separates the tear fluid in the palpebral fissure from the tears behind the eyelids. So the posterior lid border of the upper eyelid distributes the tears into the tear film, which is important for permanent moisture of the underlying tissue and for correct refraction, which means perfect visual acuity. So your eyelid margin is divided into two portions, your lacrimal and ciliary portion. Your lacrimal portion is the medial portion of the eyelid margin, and it is round and it does not contain your lashes and glands. Meanwhile, your ciliary portion contains the lashes at the anterior and sharp posterior border. So your eyelid margin contains the following. You have your mucocutaneous junction, the meibomian gland orifices, the eyelashes, the gray line, and the lash line. First, we go to your mucocutaneous junction. So your mucocutaneous junction is the transition from the keratinized stratified squamous epithelial cells of the eyelid skin to cuboidal epithelial cells of the palpebral conjunctiva. So the function of your mucocutaneous junction is that it maintains the border between your dry skin and the moist ocular surface mucosa. Next, we have your meibomian gland orifices. So your meibomian glands, they lie deep inside the tarsal plate of the posterior lamella of the eyelid. It is found posterior to your gray line. So these meibomian glands are holocrine sebaceous glands that open directly on the eyelid margin and then discharge their contents onto the lid margin. So these glands, they secrete meibum, which is an oily substance that provides a lipid base to your tear film. This lipid base is very important in helping to decrease the evaporation of tears by stabilizing tear film. So your meibomian glands are really of utmost importance for health of the ocular surface integrity and for clear vision. So if you have a dysfunction in your meibomian glands, this is the main causative factor for your dry eye disease. Next, we have your eyelashes. Your eyelashes are arranged irregularly in 2 to 3 rows. So, in the upper eyelid, you have 100 to 150 cilia, and in your lower eyelid, you will have 50 to 75 cilia. So, your eyelashes contain 2 glands, your gland of Zeiss and your gland of Mole. So your gland of Zeiss, it secretes sebum with antiseptic properties that prevents the growth of your bacteria. Next, we have the gland of Mole. The gland of Mole produces IgA, mucin 1, and lysosomes, which are really essential in the immune defense against bacteria sa inyong eyes. So when these glands become clogged or blocked, it can lead to inflammation caused by bacterial infection. Next, we have your gray line. Your gray line here is referred to as the muscle of Riolan. So your gray line, it represents the pretarsal orbicularis muscle on the eyelid margin. And lastly, we have your lash line. So your lash line is the origin of the cilia and is the most anterior line along the eyelid margin.
And now, let's discuss the movement of the eyelid. The actions of the eyelid muscles are most pronounced at the upper eyelid. Thus, opening the eye generally describes the action of elevating or lifting the upper eyelid. Conversely, closing the eye denotes depressing or lowering the upper eyelid. The position of the eyelids at rest depends on the tone of the orbicularis oculi, the levator palpebris superioris, the superior tarsal muscles, and the position of the eyeball. The eyelids are closed by the contraction of orbicularis oculi and the relaxation of the levator palpebris superioris and superior tarsal muscles. The eye is opened by the levator palpebris superioris and or by the superior tarsal, raising the upper lid. When looking upward, the levator palpebris superioris contracts and the upper lid moves with the eyeball. When looking downward, both lids move. The upper lid continues to cover the upper part of the cornea, and the lower lid is pulled downward slightly by the conjunctiva, which is attached to the sclera and the lower lid.
Good day, everyone. We are going to discuss the arterial supply, the venous drainage, the lymphatic drainage, and the nerve supply of the eyelid. First, we are going to discuss the arterial supply of the eyelids. The eyelids are supplied by a complex system of vessels that arise from both the internal and the external carotid arterial systems. The terminal branches of the ophthalmic artery, which stems from the internal carotid artery, primarily supply the eyelids, especially the upper portion. These branches include the lacrimal artery, the supraorbital artery, as being pinpointed by the pink marker, the medial palpebral artery, and the supratrochlear artery. So the lacrimal artery terminates as the lateral palpebral artery, and it supplies the lacrimal gland, the conjunctiva, and the lateral aspect of the eyelids. Meanwhile, the medial palpebral artery supplies the medial aspect of the eyelids. Then the supraorbital artery supplies the upper eyelid, the scalp, the forehead, the levator muscle, the periorbita, and the diplo of the frontal bone. Its terminal branches form anastomotic networks with their contralateral counterparts, the supratrochlear arteries, and the superficial temporal arteries. Then the supratrochlear artery, this one, supplies the medial portion of the upper eyelid, the forehead, and the scalp. It terminates by anastomosing with its contralateral counterpart and the supraorbital artery. We are now going to talk about the external carotid artery. So it supplies the superficial arterial system, which mostly supply the lower eyelid. So the facial artery becomes the angular artery, which is lateral to the nose, and it supplies the medial aspect of the eyelids. Then the superficial temporal artery and its branches, such as the frontal branch, the transverse facial artery, and the zygomatic-orbital branch, supply the lateral eyelids. Then the infraorbital artery, this one, is a branch of the internal maxillary artery, and it exits the orbit through the infraorbital foramen to also supply the lower eyelids. The collateralization between the internal and external carotid artery systems contribute to the rapid wound healing and low incidence of infection following eyelid surgery. Next, we are going to talk about the arterial arcade. So how is this formed? So the medial palpebral artery, this one, and the lateral palpebral artery, this one, anastomose to form the vascular arcades of the eyelids. So in the upper eyelid, it is composed of the superior marginal arterial arcade, this one, and the superior peripheral arcade, so this one. So the marginal palpebral arcade lies on the anterior tarsal surface 2 to 3 millimeters from the eyelid margin. Then the peripheral arterial arcade courses above and parallel to the superior border of the tarsus between the levator aponeurosis and molars muscle in the upper eyelid. In the lower eyelid, there is the marginal arterial arcade. So it arises from the medial and lateral palpebral branches running horizontally approximately 3 millimeters inferior to the lower eyelid margin and anterior to the lower eyelid tarsus. So the lower eyelid does not have a peripheral arcade like the upper eyelid. Lateral anastomosis from the zygomatico-orbital branch of the superficial temporal artery also feed into these branches. Now we are going to talk about the venous drainage of the eyelids. So the venous drainage system is through the tributaries of the ophthalmic vein and superficially through the angular and superficial temporal veins. The medial eyelid drains from the palpebral vein to the angular vein. So this one. The angular vein has a dual drainage, posteriorly into the deep venous system by the superior ophthalmic vein, and superficially and inferiorly into the anterior facial vein. The connection between the angular vein and the superior ophthalmic vein will be discussed on the next slide. Then, the anterior facial vein empties into the common facial vein, which then empties into the internal jugular vein. Then the superficial temporal vein, this one, drains the lateral eyelid, which drains to the retromandibular vein. Then it empties into the external jugular vein. Then we are now in the deep venous system. So the deep venous system draining the forehead, the eyebrow, and the upper eyelid is via the supraorbital vein, this one, which courses with the frontal vein or the supratrochlear vein, and it courses into the superior ophthalmic vein, this one. So the union between the angular vein and the supraorbital vein forms the superior ophthalmic vein, which is at the supranasal aspect of the orbit. It leaves the orbit through the superior orbital fissure, so this one, and it enters the cavernous sinus. Then the inferior ophthalmic vein is a part of the venous plexus at the anterior orbital floor that is a tributary for the lower eyelid, the lacrimal sac, the inferior rectus muscle, the inferior oblique, and the two inferior vortex veins. At the orbital apex, here, one branch of the inferior orbital vein feeds into the superior ophthalmic vein, here, so here, and it enters the cavernous sinus. Meanwhile, the other branch drains through the inferior orbital fissure to the pterygoid plexus. Next, we are going to discuss the lymphatic drainage of the eyelids. So the upper eyelid, the lateral one half of the lower eyelid, and the lateral canthus empty into the preocular lymph node and the deep parotid lymph node. Then the skin and the orbicularis oculi muscle drain into the deep cervical nodes near the internal jugular vein. Meanwhile, the medial portion of the upper and lower eyelid, the medial canthus, and the conjunctiva drains into the submandibular lymph nodes. So the lymphadenopathy may correlate to inflammation or infection of the affected anatomic eyelid structure. We are now on the nerve supply of the eyelids. So the innervation of the eyelids include both sensory and motor components. For the sensory innervation, it is supplied by the branches of the trigeminal nerve or the cranial nerve 5. So the upper eyelids are innervated by the supraorbital branch, the lacrimal branch, the supratrochlear branch, and the infratrochlear branch of the ophthalmic nerve. Meanwhile, the infraorbital branch and the zygomaticofacial branch of the maxillary nerve innervates the lower eyelid. For the motor innervation, it includes the oculomotor nerve or the cranial nerve 3, which innervates the levator palpebrae superioris, and the facial nerve or the cranial nerve 7, which innervates the palpebral part of the orbicularis oculi muscles. Then the sympathetic fibers innervate the superior tarsal muscle. So for clinical correlation, loss of innervation of the levator palpebrae superioris by the cranial nerve 3 causes an inability to open the superior eyelid voluntarily, producing a complete ptosis or falling of the upper eyelid. Meanwhile, loss of innervation of the orbicularis oculi by the cranial nerve 7 causes inability to close the eyelids tightly and lower eyelid droops away, resulting in a spillage of tears. Lastly, loss of innervation of the superior tarsal muscle by the sympathetic fibers causes a constant partial ptosis. So that's it for my part. Thank you for listening.
Hello Philippines, hello world. Welcome to the lacrimal system. Now we're going to talk about the lacrimal gland. So what do you need to know about the lacrimal gland? The lacrimal gland is a bilobe, tear-shaped gland, an exocrine gland, with the primary function of secreting the aqueous portion of what we call the tear film, thereby maintaining the ocular surface. It is primarily located in the anterior superiotemporal orbit within the lacrimal fossa of the frontal bone. The tendon of the levator palpebrae superioris bisects the lacrimal gland, giving rise to two lobes. One, we have a smaller palpebral component found continuous with the inner eyelid, and two, a larger orbital component. Its histological composition is mixed serous and mucinous acini, myoepithelial cells, and small interconnecting ductules. Now let me show you a detailed model of the eye. On this colored green structure is the lacrimal gland. This right here is the levator aponeurosis. And this right here is the levator palpebrae superioris. Now how about the structure and function? The lacrimal gland plays a prominent role in the formation of the tear film, a trilaminar structure that performs the following functions. Number 1, provides a protective barrier for the ocular surface. 2, provides a smooth optical surface at the ear cornea interface. And number 3, functions as a medium for removal of any debris. Now what is a tear film? And what is composing of the tear film? Number 1, an inner mucin layer that interfaces with the corneal surface. Number 2, middle aqueous layer. And lastly, the outer lipid layer. Serous acini are the predominant tissue found in the lacrimal gland, secreting the aqueous component, which forms most of the tear film fluid volume. The corneal surface is hydrophilic in composition, necessitating an additional component, which we call the soluble mucin, to bind to its hydrophobic surface and establish a hydrophilic character, allowing uniform adherence of the aqueous layer to the corneal surface. Mucin is secreted principally by the conjunctival goblet cells and the stratified squamous cells of the conjunctival and corneal epithelia. Within the lacrimal gland, interlobular ducts connect the orbital lobe with the palpebral lobe. tear fluid is secreted in the upper conjunctival fornix from both lobes via excretory ducts, and between 2 and 5 ducts from the palpebral lobes secrete fluid into the lower conjunctival fornix. Tear fluid originating from the lacrimal gland and other tissue drains into the nose via the nasolacrimal duct system. As you can see here, this yellow structure right here is the nasolacrimal duct. All tear fluid initially drains from the eye through the lacrimal puncti, followed by a lacrimal tubular canaliculi, nasolacrimal sac, nasolacrimal duct, the valve of Hasner, and finally into the nose. In addition to its contribution to the aqueous portion of the tear film, gladly, the lacrimal gland has adaptive immune function through myoepithelial cell secretion of IgA and IgG antibodies. It is associated with the mucosa-associated lymphoid tissue, or MALT, and is susceptible to autoimmune inflicted damage commonly seen to affect MALT. Now, how about the blood supply and the lymphatics? The arterial blood supply of the lacrimal gland is a lacrimal artery, a branch of the ophthalmic artery. Venous blood returns from the lacrimal gland via the lacrimal vein, which feeds into the superior ophthalmic vein that traverses the cavernous sinus. Now let's go back to our detailed model of the eye. This right here is a lacrimal artery. In the orbital cavity, it traverses laterally and anteriorly superior to the lateral rectus muscle, passes through the lacrimal gland. Branches are the zygomatic, muscular, and recurrent meningeal arteries, terminates as superior and inferior lateral palpebral arteries. So other than the lacrimal gland, what does it supply? It also supplies the superior and inferior eyelids and the conjunctiva. The lymphatic drainage of the lacrimal gland is by the superficial parotid lymph nodes, which drain into the superior cervical nodes. Now let's go to the embryology. The lacrimal gland is embryologically derived from immune, epithelial, and mesenchymal cell lineages. As with the most tubular organs, the development of the lacrimal gland involves a series of interactions between epithelial and mesenchymal tissue that is not entirely understood. The morphogenetic protein BMP7 is expressed in the developing gland and facilitates branching into the terminal ductal lobular units via signaling directed to mesenchymal tissue. The muscles. As the aqueous fluid is secreted from the serous and mucinous cells within the acini, myoepithelial cells are responsible for the expulsion of this fluid from the gland. The myoepithelial cells are organized around acini and ducts within the lacrimal gland and have a contractile response to neuronal stimulation. Now that's the end of the overview of the lacrimal gland. Thank you.
Good afternoon, everyone. I am Jan Samuel C. Hardenico, and I will be discussing about the innervations of the lacrimal gland. The lacrimal gland receives sensory, parasympathetic, as well as sympathetic innervation. So we will be talking about parasympathetic secretomotor nerve supply first. This nerve supply is derived from the lacrimal nucleus of the facial nerve. It has two fibers, and these fibers are the preganglionic and the postganglionic fibers. The preganglionic fibers reach the pterygopalatine ganglion, or also known as a sphenopalatine ganglion, via the nervus intermedius and its great petrosal branch and via the nerve of the pterygoid canal. On the other hand, the postganglionic fibers leave the ganglion and join the maxillary nerve. They then pass into its zygomatic branch and the zygomaticotemporal nerve until they reach the lacrimal gland within the lacrimal nerve. Parasympathetic secretomotor neurons are responsible for stimulating the secretions of lacrimal fluid coming from lacrimal glands. Now, we will be talking about the sympathetic postganglionic nerve supply. This nerve supply arises from the internal carotid plexus. It then travels in the deep petrosal nerve, passes through the nerve of the pterygoid canal, passes through maxillary nerve, goes through zygomatic nerve, and a branch of zygomatico-temporal nerve until it reaches the lacrimal gland via the lacrimal nerve. Sympathetic innervation is responsible for the regulation of the blood flow through the lacrimal gland and the glandular secretions. This illustration that is being shown to you shows the pathways of the different fibers that were being mentioned earlier. It is also good to note that the lacrimal nerve, this nerve, is responsible for the sensory innervation of the lacrimal gland. It is an ophthalmic branch of the trigeminal nerve, and as being mentioned earlier, it is responsible for its sensation. Both the postganglionic parasympathetic secretomotor fibers and postganglionic sympathetic fibers ultimately reach the lacrimal gland via the lacrimal nerve. And these are the innervations of the lacrimal gland. Thank you.
Now let's discuss the lacrimal duct. The lacrimal duct system transmits tears from the surface of the eye to the nasal cavity. The nasolacrimal duct is about 0.5 inches or 1.3 centimeter long and emerges from the lower end of the lacrimal sac. The duct descends downward, backward, and laterally in a bony canal and opens into the inferior nasal meatus in the inferior lateral wall of the nasal passage. A fold of mucous membrane known as the lacrimal fold guards the opening. This prevents air from being forced up the duct into the lacrimal sac on blowing the nose. Tears secreted from the lacrimal glands circulate across the cornea and accumulate in the lacus lacrimalis. From here, the tears enter the canaliculi lacrimalis through the puncta lacrimalis. The canaliculi lacrimalis pass medially and open into the lacrimal sac, which lies in the lacrimal groove behind the medial palpebral ligament and is the upper blind end of the nasolacrimal duct. Now let's discuss the structure and function of the lacrimal duct system. The lacrimal duct system comprises upper and lower sections. Tears first enter the upper system at the lacrimal punctum. This visible structure contains a 0.2 to 0.3 mm opening at the mucocutaneous border on each of the upper and lower eyelids. The upper and the lower lid punctae sit 5 mm and 6 mm respectively, lateral to the medial canthal edge. The punctae typically oppose each other when the eyelids are closed. After entering the punctae, tears conduct through the canalicular system. The 2 mm long vertical canaliculus extends perpendicular from the eyelid margin before widening to form the ampulla. And at the ampulla, the canaliculus makes a 90-degree turn medially. The canaliculi then continue 8 mm horizontally, following the arc of the eyelid. In addition, in 90% of the individuals, the lower and the upper canaliculi join proximal to the lacrimal sac, forming a single 3 to 5 mm long common canaliculus. For the remaining 10%, the canaliculi enter the lacrimal sac directly and independently. And just proximal to the lacrimal sac, the common canaliculus dilates to form the sinus of Meyer. Tissue infoldings form the valve of Rosenmuller, separating the common canaliculus from the lacrimal sac. This separation prevents reflux through the lacrimal system. Now let's go to the development of the nasolacrimal duct. The nasolacrimal duct forms from a cord of ectodermal cells beginning at the 7th week of development. The surface ectodermal cord joins with a growing cord of epithelial cells extending from the nasal cavity. The cord bifurcates in the canthal area, forming early canaliculi. These projections reach the lid margin at 12 weeks. By 7th month of gestation, the papilla and the punctal portion of the nasolacrimal duct system are fully formed and patent. The nasal lacrimal duct system canalizes along its extent simultaneously. The last portion to canalize and the most frequent site of obstruction is the opening to the inferior meatus of the nasal cavity. Also, after birth, the size of nasolacrimal duct system continues to increase relative to the surrounding facial structures, and the most growth occurs in the first 6 months after birth. We have here a picture of the development of the nasolacrimal duct. The first picture with letter A is at 5.5 week gestation. An ectodermal invagination forms between the lateral nasal process and the maxillary process, which becomes pinched off from the surface. Second picture, letter B, at 6 weeks of gestation, a solid cord of ectoderm is located between the primitive medial canthus and the nose. Third picture, letter C, it is at its 12th week of gestation. Proliferation of the cord occurs laterally toward the eyelid and inferiorly toward the inferior turbinate. The isolated cavities shown appear at 3 to 4 months, and the last picture, letter D, at 7th months, canalization is nearly complete, with only the puncta and the valve of Henle present. For the clinical significance, we have the most common, the nasolacrimal duct obstruction, especially to children. Up to 1 in 9 newborns have a congenital nasolacrimal duct obstruction. It most often leads to excessive tearing or epiphora. So probing of the system and sometimes stenting are interventions that open the system and permit tears to flow normally. Another obstruction is your dacryocystitis. This condition is more common in children also and is the most severe sequel, can lead to orbital cellulitis. It can be acute or chronic. Also, it could be congenital or acquired. When present, there is a medial canthal swelling of dacryocystitis, usually below the medial canthal tendon. In instant or in summary, the nasolacrimal duct obstruction is a failure of the thin tissue at the end of the tear duct to open normally. In adults, a blocked tear duct may be due to injury, infection, or a tumor. A blockage can occur at any point in the tear drainage system, from the puncta to your nose. When that happens, your tear don't drain properly, giving you watery eyes and increasing your risk of eye infections and inflammations.
Good day. My name is Paolo Guisaggio, and today I will discuss about the common problems of the lacrimal system. In this discussion, it would be divided into two according to their problems, which is infection and dry eye. For the first problem, the dacroadenitis. When we hear the word itis, it means there is inflammation. In this discussion, we will differentiate the two types of dacroadenitis, which is acute and chronic. For acute acroadenitis, it is caused by infections like viral infections and bacterial infections. And in viral infections, mumps is the most important cause of it. And in chronic dacroadenitis, it is caused by TB infection and syphilis, which remains for a long period of time in our body, and then it dissipates to different regions of the body, and one of them, in case of TB, is the lacrimal gland. Then, of course, trauma. So, for the clinical features, the most distinctive way to determine the difference between the two types of dacroadenitis is the presence of pain. In acute, there will be pain and discomfort. And in chronic, it will be painless or there will be no pain. So the characteristics of dacroadenitis to be of acute or chronic is the presence of this S-shaped curve in the eyelid. Let me explain from this diagram. First, since that it was discussed earlier that the lacrimal gland is present at the upper and outer portion of the orbit. Now, if they get inflamed, they will become red, they will become hot, and lastly, they will swell. And this swelling will cause the eyelid to move down and have a specific characteristic of this S shape in this picture as what we can see in the right side. Thus, the displacement of the eyelid will cause the eyeball to move downward and inward, and it will become more painful in acute and painless in chronic. So remember that this S-shaped configuration is the cardinal sign of dacroadenitis. Further, we will talk about the dry eye. So whenever the lacrimal gland have hypofunctioning or they are completely destroyed, it will lead to the decreased production of the lacrimal fluid. When there is decreased production of lacrimal fluid, there will be irritation, redness, and blurring because when there is reduced amount of lacrimal fluid, this blinking of the eye will produce friction. And because of this friction, these symptoms will be produced and will fatigue the eye. And this is called keratoconjunctivitis sicca. Causes would include congenital agenesis, damage to the trigeminal nerve, and idiopathic hyposecretion. For the pathophysiology of keratoconjunctivitis sicca, what happens is when there is the absence of the when there is absence of the damage of the lacrimal gland, there will be dry eyes, and there will be lead to aberrations because of every blinking of the eyelid. There will be friction force, which will cause the aberrations, redness, and swelling of the eye, as what we can see in the picture. Thank you.
Clinical correlate of the lash line. First would be trichiasis. Trichiasis is described as the normal lashes growing inward. In this situation, the lash follicle is normal, but the direction of lash growth is abnormal. In the presence of inflammation, there may be a misdirection of the follicle with the lash growing inward towards the cornea. Mostly, it affects the lower eyelid, except in chemical burns where both lids are affected, or trachoma where the upper eyelid is more severely affected. The signs of trichiasis is of course the posterior misdirection of normal lashes, which most frequently affects the lower lid. Its complications would include inferior punctuate epitheliopathy, corneal ulceration, and pannus, which is the presence of an abnormal layer of fibrovascular tissue. For the short-term treatment, epilating the lashes or inserting bandage contact lens is done. Permanent destruction of the roots of the offending lashes is achieved by argon laser, electrolysis, radiofrequency, epilation, trephination, eyelash bulb extirpation, resection of the lash follicle, cryotherapy, and surgical repositioning. Also, radiofrequency needle is being used to reach the depth of the roots of the lashes, which is 2.4 mm deep in the upper lid and 1.4 mm in the lower lid, to kill the offending lash roots. Second would be dystichiasis. Dystichiasis means double eyelashes, as seen on the picture depicted on the right side of the screen. Its signs would include decreased vision, pain in the eyes, redness, irritation, foreign body sensation, and watering. Complications would be corneal scarring, thinning of the cornea, and corneal ulcer. Treatment would include lubricating eye drops and ointment, soft contact lenses, epilation with electrolysis, cryosurgery, laser thermoablation, radiofrequency ablation, and lead splitting procedure. Epilation with electrolysis is useful in treating small numbers of isolated or focal areas of distichiasis. It may be done under local anesthesia, but general anesthesia may be required in children. Cryosurgery may be done to treat wider areas of distichiasis. Cryophobe freezes the lash follicles and destroys it. Since this approach is non-selective, it may permanently damage the normal anterior eyelashes, leading to madarosis, which is loss of eyelashes, and it should be avoided in cases with ocular cicatricial pemphigoid. Laser thermoablation may be used to destroy eyelash follicles. Radiofrequency ablation uses a small gauge wire introduced alongside the lash to the follicle for destruction with radiofrequency, while lid splitting procedure involves an incision in eyelid margin immediately anterior to the dischiatic cilia. The dischiatic lash follicle is treated with direct application of electrolysis, excision, or cryotherapy, and then the lid incision is closed. Third would be chronic marginal blepharitis. Blepharitis is defined as an inflammation of the base of the eyelids. Blepharitis can occur anteriorly or posteriorly. The one that occurs anteriorly is called staphylococcal blepharitis, bacterial blepharitis, or ulcerative blepharitis. Its causative agent is Staphylococcus aureus. It is caused by a chronic infection on the anterior part of the lid margin and it is seborrheic. The one that occurs posteriorly is called meibomianitis or meibomian seborrhea. The signs and symptoms of blepharitis would include shiny anterior lid margin, hyperemia of lid margin, greasy scales, lashes stuck together, water eyes, itchy eyelids, and sensitivity to light. Complications would be eyelash problem, eyelid skin problems, excess tearing or dry eyes, sty, chalazion, chronic pink eye injury to the cornea. It is best treated by lid hygiene using 25% baby shampoo, tear substitutes for associated tear film instability, systemic tetracyclines for severe posterior blepharitis, and warm compress to melt solidified sebum in posterior blepharitis. Last would be sty. Sty is also called as hordeolum. It is an infection of the sebaceous gland at the base of the eyelashes. As seen on the picture, it appears as a red, painful bump that forms on or inside the eyelid near the edge of the eyelashes. Signs and symptoms would include painful red bump along edge of the upper and lower eyelid near the base of the lashes, swelling of the eyelid, crusting along the eyelid, sensitivity to bright light, sore, scratchy eye, and tearing of the eye. Complications would be progression to chalazion that causes cosmetic deformity, corneal irritation, or need of surgical removal. So there are two ways to treat sty. First would be self-care, wherein you apply warm washcloth to the eyelid for 10 to 15 minutes at a time. It is done 3 to 5 times a day. Gently wipe away eyelid drainage with mild baby shampoo and water. It is important to remember not to squeeze or pop a sty. Do not rub or touch your eyelid. Do not wear makeup or contact lenses. If the sty does not improve after 48 hours of self-care, it may require medical treatment done by a doctor. In-office incision under local anesthesia to drain sty, antibiotic treatment or eye drop, and steroid injection into the sty to reduce the swelling in the eyelid.
Meibomian glands, or tarsal glands, are modified sebaceous glands embedded in the tarsi, margin of the eyelids or the edges which touch when the eyelids close. It is yellow and arranged in approximately 25 parallel rows perpendicular to the eyelid margin in the upper lid and slightly fewer in the lower lid. The sebaceous secretion of the tarsal gland spreads over the margins of the eyelids, and so an oily layer is drawn over the tear film as the palpebral fissure opens after a blink, reducing evaporation and contributing to tear film stability. The tear film is made up of water and oily layer. The tear film lubricates and keeps the surface of our eyes healthy. It also affects how we see. If either the water or oily layer is decreased or is of poor quality, we may have symptoms of irritation and or blurred vision. The presence of the oily hydrophobic secretions of tarsal glands along the margins of the eyelids also inhibits the spillage of tears onto the face. So what is MGD? MGD means meibomian gland dysfunction. It refers to the condition where the glands are not secreting enough oil or when the oil they secrete is of poor quality. Often, the oil gland openings get plugged up so that less oil comes out of the glands. If ever the oil comes out of it, it can be granular, crusty, or otherwise unhealthy and can cause irritation. MGD is very common. In the early stages, patients are often asymptomatic, but if left untreated, MGD can cause or exacerbate dry eye symptoms and eyelid inflammation. The oil glands become blocked with thickened secretions. Chronically clogged glands eventually become unable to secrete oil, which results in permanent changes in the tear film and dry eyes. So the next one is chalazion, also known as meibomian cyst. It is painless, roundish, firm within tarsal plate of meibomian glands at the base of the eyelid. It may rupture to the conjunctiva and cause granuloma. The treatment is injection of local anesthesia, insertion of clamp, incision, and curettage. The next one is hordeolum. It is usually caused by a bacterial staph infection and results in pain, swelling, and redness. A hordeolum looks like a pus-filled lump or pimple at the edge of the eyelid. There are two kinds of hordeolum, the internal and the external. The internal hordeolum is a staphylococcal abscess of meibomian glands, while the external is a staphylococcal abscess of lash follicle and zase, also known as small sebaceous, or molly, which is the small sweat glands. So they're both tender swelling. The discharge also can be discharged through the skin. So here is a summary of the difference of hordeolum and chalazion. As you can see, the location of hordeolum most commonly found at or near an eyelash follicle, while the chalazion is most commonly found above the eyelashes on the upper lid. And this is the significant difference between chalazion and hordeolum, because hordeolum is caused by a bacterial infection, either at the root of the eyelash follicle or in the oil glands of the lids. A blocked oil gland for chalazion, of course. The tenderness can only be found in hordeolum, while the chalazion is painless. So their treatments are spontaneous drainage and warm compresses, while in the chalazion is surgery and antibiotic eye drops. That will be all. Thank you.
Let's proceed to the excretory apparatus of the lacrimal system. First is the puncta and the canaliculi. The lacrimal excretory system starts from the lacrimal puncta, which lies at the medial ends of both upper and lower lids. In this picture, the superior lacrimal punctum is located in here, and below it is the inferior lacrimal punctum. Each puncta is surrounded by its respective ampulla and leads into the canaliculi. The canaliculus has a 2 mm long vertical portion and an 8 mm long horizontal portion. Next is the lacrimal sac. The lacrimal sac, as seen in the picture, is in here. The lacrimal sac lies in the lacrimal sac fossa, which is bound by the anterior and the posterior lacrimal crest. The length of the lacrimal sac is around 12 to 15 mm. As seen in the picture, the lacrimal sac continues inferiorly into the nasolacrimal duct. The nasolacrimal duct is 12 to 18 mm in length and travels within the bony nasolacrimal canal in a downward, background, and lateral direction. The duct finally opens into the inferior meatus of the nose. This opening is partially covered by a mucosal fold, the valve of Asner. Infection or inflammation of the lacrimal sac is called acute dacryocystitis. It is usually secondary to nasolacrimal duct obstruction that develop into an abscess. It is manifested by a sudden onset of pain, erythema, and edema overlying the lacrimal sac region. There is a tender canthal swelling, usually located below the medial canthal tendon, and a mild preseptal cellulitis. For the treatment, antibiotic therapy is usually prescribed, but surgery is the definitive treatment. For pediatric dacryocystitis, it may respond to probing or Krigler massage. But for the adult dacryocystitis, it requires dacryocystorynostomy that usually performed either externally and endonasally. That ends our report. Thank you all for listening.